The cardiomyopathies are a diverse group of disorders that primarily affect the myocardium, as in this case of idiopathic dilated cardiomyopathy. A World Health Organization task force has defined cardiomyopathies as heart muscle diseases of unknown cause. By this strict definition, specific heart muscle disorders, such as coronary heart disease, alcoholic heart disease, and cardiac hemochromatosis, are not included as cardiomyopathies. The cardiomyopathies are classified as dilated cardiomyopathy, hypertrophic cardiomyopathy, which may be either obstructive or non-obstructive, and restrictive cardiomyopathy. For this video presentation, we will discuss these entities in this sequence. Dilated cardiomyopathy is characterized by ventricular enlargement with reduced systolic function. In this anatomic specimen, all four chambers are enlarged. The left ventricular walls are usually normal in thickness, but since the cavity is dilated, the LV mass is increased. In some advanced cases with marked LV dilatation, the walls may appear thinner. Contrast this heart of a patient with dilated cardiomyopathy with the heart of an age-matched patient who died of non-cardiac causes. In patients with dilated cardiomyopathy, 2D and M-mode echo allow precise measurement of chamber dimensions. Left ventricular function can be calculated, and a visual estimate of right ventricular function can be obtained. And 2D echo also allows detection of mural thrombi, which may occur in either the left or right ventricle. This is a parasternal long-axis diastolic still frame from a 77-year-old female with idiopathic dilated cardiomyopathy. The left ventricular chamber and the left atrium are enlarged. The left ventricular walls are normal in thickness. This frame was selected because the mitral leaflets are at the point of maximal early opening excursion. Note the 2.5 centimeter displacement of the mitral anterior leaflet from the septum. Normally this separation is less than 7 millimeters. As left ventricular systolic function deteriorates, the mitral leaflets are displaced further posteriorly. In real time, you will note that LV systolic function is severely reduced. Her ejection fraction was 27%. This is a parasternal short axis view from the same patient at the level of the papillary muscles. The reduction in global systolic function is apparent. Note that the regional wall function may not always be uniformly reduced in patients with dilated cardiomyopathy. Frequently, the contractility of the basal and mid infralateral wall segments is better preserved than the contraction of the remaining segments. M-mode can be used for chamber measurements and to study valve motion. In this parasternal long axis view, an M-mode cursor has been placed across the right and left ventricles. The RV is enlarged. The left ventricular diastolic dimension is 66 millimeters, and the systolic dimension is also increased, 60 millimeters. The reduced systolic thickening of the septum and posterior wall is evident. The cursor has now been moved to the level of the mitral valve. It is easy to appreciate on the M mode the increased E point septal separation, which is 2.2 centimeters. The reduced separation of the mitral leaflets in diastole is due to low output. The cursor now crosses the aortic valve and left atrium. The sweep speed of the M mode has been increased to emphasize the decreased motion of the aortic root and the tapered closure of the aortic cusps, both manifestations of the reduced cardiac output. This 56-year-old male has enlargement of both ventricles. In real time, you will see that both left and right ventricular systolic function are severely depressed. His ejection fraction was 14%. This is an apex down four-chamber view from a 54-year-old male with dilated cardiomyopathy. In contrast to the previous case, note that the right ventricle is normal in size, despite the huge left ventricle. Right ventricular systolic function is preserved, while the left ventricular ejection fraction was calculated as 10%. Note the marked rocking motion of the heart. The severe uniform reduction in global LV function is also evident in this apical long axis view. This 77-year-old male with dilated cardiomyopathy has enlargement of all four chambers. We have selected a 3.75 megahertz transducer and adjusted the gain upward in the ventricle to demarcate the swirling flow. Note the smoke-like echoes which move like a pinwheel in the LV. This swirling pattern is a characteristic of severe low output states. Mural thrombus, with its potential for systemic embolization, is one of the most dreaded complications of dilated cardiomyopathy. If mural thrombus is recognized soon enough, embolism can be prevented by anticoagulant therapy. This is a huge apical thrombus in a 29-year-old male with idiopathic dilated cardiomyopathy. This is an apical short axis view, again demonstrating the large mural thrombus which fills the apex. While 2D echocardiography is used to readily identify the structural and functional abnormalities that are characteristic of dilated cardiomyopathy, Doppler and flow imaging are utilized to delineate hemodynamic derangements. These include valvular regurgitation, determination of pulmonary artery systolic pressure, identification of a characteristic swirling pattern of left ventricular inflow, characterization of diastolic dysfunction, and determination of cardiac output. We will now discuss each of these applications. Significant left ventricular enlargement results in dilatation of the mitral annulus and in malpositioning of the papillary muscles in relationship to the mitral leaflets, resulting in incomplete apposition of the leaflets. Hence, some degree of functional mitral regurgitation is present in most patients with dilated cardiomyopathy. Since this functional regurgitation tends to respond nicely to afterload reducing agents, it is important to be able to characterize the degree of mitral regurgitation for each patient with dilated cardiomyopathy. We have narrowed the sector to enhance color flow imaging of the regurgitant jet. This patient has moderate regurgitation. The jet fills the lateral portion of the left atrium. This 77-year-old female has an ejection fraction of 27%. Note the jet of mild mitral regurgitation. This patient with dilated cardiomyopathy also has severe reduction in LV function. In this case, mitral regurgitation is severe. The broad color jet nearly fills the left atrium. Tricuspid regurgitation is also found in almost all patients with dilated cardiomyopathy. This patient has severe mitral and tricuspid regurgitation. We are now directing attention to the tricuspid regurgitant jet. In the real time sequence which follows, you will notice that the amount of tricuspid regurgitation is phasic. It lessens with expiration. But with cycles such as this, recorded during inspiration, the mosaic jet fills the enlarged right atrium. Not only is the color flow analysis of tricuspid regurgitation useful for patients with dilated cardiomyopathy, but continuous wave Doppler determination of the TR velocity is also important. This 69-year-old male with dilated cardiomyopathy demonstrates enlargement of all four chambers. His left ventricular ejection fraction is severely reduced at 13%. And his right ventricular function appears moderately reduced. A non-imaging Doppler probe was placed at his apex and directed toward the mitral valve. This is the continuous wave Doppler spectrum of mitral regurgitation. The strength of the signals suggests that the regurgitation is of significant degree. The peak velocity is relatively low for MR, being 4 meters per second. Using the Bernoulli equation, this indicates a 64 millimeter systolic gradient between left ventricle and left atrium. Since his systolic blood pressure was 90 millimeters of mercury, his left atrial pressure is approximately 26 millimeters of mercury. Furthermore, note this gradual rate of increase of the MR velocity, which indicates LV dysfunction with decreased rate of pressure generation. One would now want to determine if the right-sided enlargement and RV dysfunction are due to pulmonary hypertension, secondary to his left-sided findings, or if the RV is simply involved with the myopathic process. This patient had only mild tricuspid regurgitation. a faint but complete envelope of TR was detected with the CW probe. The peak velocity is 3 meters per second. You will recall from tape number 6 that by inserting this TR velocity into the Bernoulli equation, we arrive at the systolic gradient between right ventricle and right atrium. 3 squared times 4, which is 36 millimeters of mercury. Right atrial pressure was estimated to be 14 millimeters of mercury. The right ventricular pressure is found by adding the right atrial pressure to the systolic gradient. 14 plus 36 equals 50 millimeters of mercury. In the absence of pulmonary stenosis, this RV systolic pressure is equal to the pulmonary artery systolic pressure. In this patient who had systemic hypotension with a systolic blood pressure of 90 millimeters of mercury, this pulmonary artery pressure of 50 millimeters of mercury represents moderate pulmonary hypertension. You will recall that with normal left ventricular size and function, flow through the mitral valve is directed toward the apex, and red color signals promptly fill the left ventricle during the apical examination. With systole, this blood is vigorously ejected through the aortic valve, hence this column of blue on the color flow exam. We have already mentioned that with left ventricular enlargement and reduced function, the mitral apparatus becomes displaced from the septum. In this apex down orientation from a 56-year-old male with idiopathic dilated cardiomyopathy, note that the mitral orifice is oriented toward the lateral wall of the left ventricle. Mitral flow in diastole is directed toward the lateral left ventricle. In real time, in addition to mild mitral regurgitation, you will see that in diastole, boluses of red color inflow swirl along the lateral wall towards the apex, and then turn toward the base, becoming encoded in blue. This clockwise swirling pattern of left ventricular filling is typically seen in dilated cardiomyopathy. Abnormal left ventricular filling can be better characterized by pulsed wave Doppler. As we discussed on tape number 2, we inspect left ventricular inflow by placing the sample volume near the tips of the mitral leaflets. To review, normal mitral inflow is characterized by 2 peaks, an early E velocity and a late A velocity. The E velocity is normally greater than the A velocity, such that the E to A ratio is greater than 1. Normal deceleration time is between 160 and 230 milliseconds. Normal isovolumic relaxation time is less than 90 milliseconds. This 83-year-old female has dilated cardiomyopathy with severely reduced function and an ejection fraction of 19%. A pulsed wave sample volume has been placed at the tips of the mitral leaflets. The pulse wave velocity profile shows a single spike. As is often the case in patients with severe congestive heart failure, this patient was tachycardic. Carotid sinus massage was performed, and as the heart rate slowed, the E and A velocities could be clearly distinguished. We currently recognize 2 different abnormal diastolic patterns. Patients with dilated cardiomyopathy can have either pattern. This is the more common. The A velocity is very prominent compared to the reduced E velocity, and the deceleration slope is prolonged. This is the pattern of abnormal relaxation. This dilated cardiomyopathy patient demonstrates an exaggerated abnormal relaxation pattern. His E velocity is almost non-existent, at less than 0.2 meters per second, while his A velocity is greater than 1 meter per second. The second type of abnormal diastolic profile is illustrated by this 20-year-old male with dilated cardiomyopathy. The E velocity is nearly 1.1 meters per second with a small A velocity, and note that the deceleration slope is steep. Here we are measuring the deceleration time, which is short, 110 milliseconds. We refer to this as a restrictive pattern. It is usually associated with a more symptomatic state and likely indicates a poorer prognosis. It is important to note that dilated cardiomyopathy patients may be converted from one diastolic pattern to another with progression of disease, as well as by altering loading conditions. This patient has an ejection fraction of 10%. As mentioned on previous tapes, 2D and Doppler can be used to calculate cardiac output. For review, the stroke volume is the product of the left ventricular outflow tract time velocity integral and the area of the left ventricular outflow tract. This is an expanded parasternal long axis view from the same patient. The image has been frozen in systole. One caliper has been placed at the junction of the anterior aortic cusp and the septum, and a second caliper has been placed at the junction of the posterior aortic cusp and the anterior mitral leaflet. The left ventricular outflow tract diameter measures 2.27 centimeters. Using the apical long axis format, a pulsed wave sample volume has been placed in the left ventricular outflow tract, just below the aortic valve. This is the corresponding pulsed wave spectrum with a maximum velocity of 0.6 meters per second. The pulsed wave envelope has been traced, and the instrument has calculated the time velocity integral, 10.4 centimeters. The left ventricular outflow tract area is the square of the LVOT diameter times 0.785, or 4.04 square centimeters. Multiplying this area times the LVOT TVI yields the stroke volume, 42 cc's. The patient's heart rate was 100 per minute at the time of the Doppler measurements. Multiplying the stroke volume times the heart rate gives us the cardiac output, 4.2 liters per minute. Dividing by the patient's body surface area, 1.89 meters squared, we calculate the cardiac index, which is reduced at 2.2 liters per minute per meter squared. The combined use of 2D, Doppler, and flow imaging provides a comprehensive assessment of structural and functional abnormalities in patients with dilated cardiomyopathy. Left ventricular ejection fraction is prognostic, while serial assessment of diastolic dysfunction, pulmonary artery pressure, cardiac output, and mitral regurgitation can be used to assess the efficacy.